Dr. YASHPAL Rana, Consultant Cardiovascular Radiologist at MEHTA Institute of Cardiology and Research Center and at RADISCAN Diagnostics, Ahmedabad. I welcome all of you for Case of the Week series of YouTube channel of Gujarat State Chapter of IRIA. This is case number 2, which I have titled as A Balloon of IVC. A 24-year-old female presented with complaints of dyspnea, fatigue, and occasional abdominal pain. On examination, patient had high blood pressure, urine analysis showed microscopic hematuria, and rest of all blood investigations were normal. 2D echo was performed for dyspnea, which showed dilated right atrium and ventricle, as well as dilated suprahepatic segment of IVC, and hence Doppler study of IVC and renal veins were requested. Ultrasound and Doppler revealed dilated bilateral renal veins with fusiform aneurysmal dilatation of suprarenal IVC and small right kidney. IVC aneurysm was presumed to be idiopathic. As we see in these ultrasound images, there is large IVC aneurysm, dilated left renal vein, and dilated tortuous right renal venous channels. MSCT pulmonary angiography with IVC venogram was advised for detailed evaluation to see the extent of IVC aneurysm and to rule out pulmonary embolism. As we see in these CT images, these 3D and MIP MSCT images demonstrate renal artery to venous fistula. Contrast jet as shown in these images was visible. There was also an additional finding in form of a small aneurysm of left intralobar artery. Right kidney was smaller in size due to shunting of blood. Left renal vein was also dilated. And as I mentioned, a small arterial aneurysm was detected in upper polar intralobar renal arterial branch of left kidney. Conventional angiography was done to confirm the findings and for coiling of right renal arteriovenous fistula at the same time. 3D volume rendered CT images demonstrating renal artery to venous fistula as a cause of IVC aneurysm along with left intralobar renal artery aneurysm. These are the catheter angiography images which confirmed right renal artery to venous fistula as a cause of this large IVC aneurysm along with confirming left intralobar renal artery aneurysm. So coming to the discussion and teaching points, in the world literature, very few cases of IVC aneurysms have been reported. IVC aneurysm secondary to renal arteriovenous fistula is very rare. The diagnosis of underlying cause of IVC aneurysm like renal arteriovenous fistula, as in our case on MDCT, not only saved the patient of further unnecessary investigations but correctly guided the patient management in form of coiling of the fistula. As left renal arterial aneurysm was small and asymptomatic, it was not treated and patient was put on follow-up. Two different classification systems for IVC aneurysms have been defined in the literature. 3 types are recognized according to the classification of Thompson and Lindenauer: congenital, acquired, and secondary to arteriovenous fistula. The Gradman and Steinberg classification defined 4 types. Type 1 is aneurysms of the suprahepatic IVC without venous obstruction. Type 2 is aneurysms associated with interruption of the IVC above or below the hepatic veins. Type 3 are aneurysms confined to the infrarenal IVC without associated venous anomaly. And type 4 describes miscellaneous. Arteriovenous fistulas comprise 70 to 80% of arteriovenous communications in the kidney. They can result from trauma, surgery, tumors, inflammation, or erosion of an aneurysm directly into vein. AVFs typically have a single feeding artery and a single draining vein, both of which are markedly enlarged. The most common clinical manifestation of a renal arteriovenous fistula is an abnormal bruit. Congestive heart failure occurs in 1/2 of symptomatic patients. Persistent or delayed hematuria is also common. Ischemia in the renal parenchyma distal to the arteriovenous fistula may induce renin-mediated hypertension and impaired renal function. Thank you very much. Please do subscribe, comment, and join us again next week for the Case of the Week series. Thank you again.